Heart failure is not a primary condition. This is rather a syndrome, meaning it's a state. Okay. So when a patient is diagnosed with heart failure, that means they have some underlying condition that led to this permanent condition. Heart failure is a chronic condition. However, it can have acute episodes. So just like COPD, diabetes, this is a chronic condition, has no cure, and will have acute exacerbations. When we say acute exacerbations, they're flare-ups. Okay. So most common causes of flare-ups is the patient got sick, meaning their heart decompensated as a result. They got the flu, they got some acute condition. Okay, so an acute infection usually. Other causes of exacerbations or flare-ups are when the patient is non-compliant with their medications or with their diet. Examples are somebody's having a birthday in the family, okay, or there's a fiesta, they're on vacation. So it's hard to stay with the prescribed diet, yeah? So you can't stay with the low salt diet when you have all this food on your table, all right? And you're with company, okay, so you can't blame the patient. They're alive, so they will continue to live. So unfortunately, they will have exacerbations. Another is with the medications. Now, these medications have side effects, which are most of the time unpleasant. These patients will be on diuretics forever. So it's not easy being on diuretics. If you've ever been on one, it's hard because it's inconvenient. You have to get up to go to the bathroom multiple times. And it's maybe okay if you're retired and at home, but most people with heart failure are not retired. Okay? They are working individuals, professionals like you and me. So they're at work and they have to take the same treatment just like anybody else. So there will be exacerbations. Don't worry, they will keep you employed because otherwise, without these patients, who are we going to take care of? Yeah. So you'll be called off. Okay, we have no patients, census is low, so you'll stay home. All right. But doesn't mean, we don't teach them. Of course, we want the best for all our patients. We don't want to see them in the hospital, but this is the reality. Okay. So the patient will have episodes, several of them, of acute decompensated heart failure. The reasons I described to you, some reasons, of course, are specific to the patient. Maybe the patient can't afford the medications. Maybe they have no insurance. So there are so many people living with heart disease, with heart failure all throughout the country, all throughout the world. In my family, I have a brother-in-law. He's not that old. He's only in his 40s, but he does smoke a lot. He does drink a lot. So he developed heart failure at a young age. I think he was diagnosed before he reached 40. And let's go to the cause. Now, there are risk factors for heart failure. The number one risk factor is coronary artery disease. I'm sure that's not the first time you've heard that term. You've heard that term in fundamentals and especially in MedSearch 1. Okay, we'll talk about coronary artery disease and acute coronary syndromes, meaning coronary vascular disorders next semester for module 1 on your 5th semester. But here we are. So atherosclerosis, what is atherosclerosis again? Of the arteries. So this is arterial disease. Now, when you have atherosclerosis, there are two types. You got arteriosclerosis and also the atherosclerosis. It's a broad term. Okay? It can be also not just the hardening, but also the narrowing. Root cause, of course, is metabolic syndrome. There are 4 conditions under metabolic syndrome. You have obesity, you have high cholesterol, you're pre-diabetic, and or hypertensive as well. So atherosclerosis doesn't just develop heart failure, it will cause acute coronary syndromes, including a heart attack, for instance. And because the risk factors are shared, meaning these patients are overweight or obese, they're hypertensive, diabetic. So therefore, they will share the same complications. These patients are high risk for stroke and heart attacks. Let's go to the pathophysiology. All right. The pump here fails to do its job. So let's describe the job of the heart. The job only does two things. It's going to receive blood, and once it receives that blood, it will have to pump that blood out. Oh, I forgot my pen. Okay, I'll try. So here's your heart. We have two sides of the heart, correct? We have the right side and the left side. This is the right atrium, right ventricle. We have the left atrium, then the left ventricle. Right? Okay. Then you have a superior vena cava here, inferior vena cava, both emptying into the right atrium. And from the right atrium, it will pass through what is this valve called? Okay, bicuspid. And then the right ventricle will pump it to where? Okay, there are pulmonary arteries coming out of the right ventricle, and they will go both into the right and left lungs. Okay, so you have two lungs here. Okay. And then from the lungs, they will return via the pulmonary veins into the left atrium and through the mitral valve, and then through the into the left ventricle, and then it will come out of the aorta into the systemic circulation. All right. So the problem comes, since you have two sides of the heart, either side can fail. No matter how you look at it, the entire heart will eventually fail, meaning it may begin as right side only, left side only, but eventually both sides will fail. Okay. What's the root cause again? Atherosclerosis, right? So the patient's heart fails. Okay, although there are two types of heart failure, we have direct heart failure and we also have indirect heart failure. But for this chapter, let's talk about direct heart failure. So this patient's heart failed. So let's use a heart attack as an example. So patient suffered a heart attack, but let's say it's the right coronary artery. Okay. So let's look at first what happens if the right side of this heart fails.
They hardened up because of cholesterol, right?
The coronary arteries?
Yes.
Yes. So the, right, remember the heart is a muscle. So it needs blood supply itself. So the blood we're talking about today so far is the blood flow inside the heart chambers.
Oh.
Meaning the heart, the blood that is being pumped by the heart. But remember, the patient's heart is also a muscle. The heart itself needs its oxygen supply first. Now, the blood that enters the chambers does not perfuse the heart muscle. So it has to wait until the blood comes out of the aorta and then falls back and enters the coronary arteries. The coronary arteries are at the base of the aorta, right? Meaning the heart doesn't get any blood at all when it pumps. It has to wait until it relaxes and blood falls from the aorta, because blood will move like this, right? They move in bursts. It's not like a faucet wherein you open the faucet, blood will just keep flowing. Doesn't work like that. Our blood circulates through heartbeats. Okay, so as the heart beats, yeah, blood will move, blood will move, blood will move. Okay, so it's not true that the blood is just constantly moving like this. No, it goes in spurts. Okay, they move in spurts, right? They move because the heart is pumping. So therefore, heart doesn't pump. What will happen to blood flow? Does it move? It can't move, okay, because there is no pumping action. All right. Okay, so that's how it works. So as blood comes out of the left ventricle, comes out to the aorta, the heart will have to relax. The ventricles have to relax, right? So as the ventricles relax, blood will fall back, correct, by gravity. When it falls back, then it will fill the coronary sinuses. You will fill, let me show you the on your chapter. So on the previous chapter under the anatomy and physiology, okay, so these are the chambers of your heart. So this is where blood flows. So as we discussed earlier, the um, blood will enter the right atrium, right? And then the right ventricle comes out, leaves the heart, goes to the lungs to get oxygen, returns to the heart via these two pulmonary veins, entering the left side. Okay. And then from the left side, it enters the left ventricle from the left atrium, left ventricle, and then comes out of the aorta. So what I'm talking about is as this blood here, as the blood leaves the heart, the aorta, when the ventricles contract, correct? Specifically the left ventricle. When it relaxes, blood, of course, will fall back. The coronary sinuses are here. That's the electrical conduction. Okay, I don't have a drawing. Okay. So there are let's open a new. Okay, so here are your coronary arteries. You see what I'm talking about now? Okay, so as the blood falls back on the aorta, it will fill the coronary arteries. Okay, so there's no such thing as when the heart pumps, it does not fill the coronary arteries. So you can see why is the diastolic pressure lower than the systolic pressure? Why? This is the reason. Okay, so therefore the diastole is measuring pressure in the arteries when the ventricles are relaxed, right? So it's during the diastole that your coronary sinuses fill with blood and perfuse your heart. Okay, let's go back here. So let's say the right side fails, right? Let's use this one. This is a better. This is a better illustration. Let's use this one. All right. So if the right side fails, this side here, what's the job of the right side of the heart? What does it do? Receives, yeah, blood, oxygen, less oxygen, blood, from where? Where did they come from? All over the body, right? So the superior vena cava, you got it from where?
Top of the body.
Okay, so from the shoulders and the head, right? Go through the neck, the jugular vein, and then becomes the superior vena cava, and enters it. What about the inferior vena cava? Where does blood come from? from GI tract, starting from the esophagus. So the esophagus is somewhere here and drains into from the stomach into the liver and then enters here, right? So the liver is right here before the inferior vena cava forms, correct? And the rest of the body also, the rest of the GI tract, your legs, your kidneys, they all drain into the inferior vena cava, right? So what happens if the right side fails? When we say it fails, it does not pump effectively. It's weak. It's not pumping correctly. It's just doing this. Okay? Very ineffective. Can it do its job? Its job is there are only two things that the right side of the heart does. What are they again? Receives blood, and then what does it do with that blood? Pumps it where? To the lungs, right? Okay, so that's the job of the right side. Receives blood from all over the body and then pumps it where? To the lungs to get oxygen. Okay, so imagine what happens if this guy fails. This side fails. So what happens to those two things it's supposed to do? Okay, so let's look at the receiving part. So if it can't receive blood, okay, so if it can't receive the blood from the rest of the body, all over the body, what will the patient look like? So there will be edema, right? So there will be congestion. Remember we talked about it last week? When there is congestion from increased hydrostatic pressure, what will form? Edema. Okay, so where will you find edema in these patients? In the legs, and the arms. Okay, so what happens to the neck veins? Okay, distend. Okay, so what happens to the liver? Some things you can't see. So here in the liver, what will happen to the liver? Or there will be congestion there, correct? And then when it pushes down, where will the water go? Still the same, hydrostatic pressure. So water will be pushed out, where will they go? Into the abdomen. Okay, so there'll be large liver, and then of course there'll be water in the abdomen as well, the peritoneal cavity, water in the arms, the legs. And then let's look at the other job. So it's supposed to receive blood, and then what does it do with that blood again? Pump it. So can it pump? It's trying to pump, but is there enough blood that goes to the lungs? Not enough. Of course, there will be some blood that goes there, but not enough. So can you imagine now what will be the manifestations if there's right side failure? Okay, so we just talked about it. Okay. Now let's go to the left side. So what happens if the left side of this patient's heart fails? Now this side, what's the job of the left side? So just like the right, it will receive blood and it will pump that blood out. Where did it receive blood from? The left side. So the left atrium gets blood from where? Which came from the lungs, right? Okay, so now you have lungs here, left, right lungs. That blood that the right side pumped to the lungs is supposed to return to the heart on the left side now. So if the left side doesn't work, meaning the patient has left side heart failure, what happens to the patient? Where did that blood come from again? It's supposed to enter it?
On the lungs.
The lungs. So what happens to the blood from the lungs?
Difficulty of breathing.
Okay, so there'll be congestion in the lungs, right? There's so much blood there. So same thing, hydrostatic pressure again increases because of congestion. So it will leak water, correct? So where will that water go? Might be lungs. It will go into the alveoli. So the patient's lungs will be very wet. Okay, so what do we call those sounds again? Crackles. Very good. Meanwhile, on the left ventricle, so how much blood is coming into the left side? This is failing. Okay, and then what can this left ventricle do to that blood? So let's say there's blood here now, there's congestion, there's also congestion in the lungs, but the left side, the left ventricle can't pump it effectively. It's trying to pump it, but very weak. So what happens? What is it supposed to do? pump it into the aorta, correct? And where would that blood go? Everywhere, right? First two branches, what do you call these two? So the carotids, right? So what happens to blood going to the brain? Less. Remember that blood carries oxygen. So there'll be less blood going to the brain. What about the rest of the body? There's less blood going to the brain. The rest of the body, will they get any? Also, very little as well. And then what did we say last week? What will this automatically trigger? Okay. This is low cardiac output, yeah? So if there's low cardiac output, that means what happens to oxygen level? What happens to blood pressure? What happens to cardiac blood volume? Low. What happens to sodium and sugar levels? Also low. So what will be automatically triggered again? RAS will be activated and not mentioned in that chapter in blue electrolytes. We assume that what will also be automatically stimulated, sympathetic, right? So sympathetic nervous system. So this is now what's happening. The patient is in failure. It can't do its job on the right side or the left side. And what is automatically triggered again? Right, so which results in what two conditions? Now, what are the effects if there is angiotensin and aldosterone release? Vasoconstriction, and then there is what happens, the aldosterone is also released. So, what is the effect of aldosterone again? Water and sodium, right? So what happens to blood volume? Increases further. Remember, the problem is this guy can't do its job. That's why there's already congestion. So what's the renin-angiotensin? Plus you have sympathetic response. Epinephrine is automatically released, which increases heart rate and causes further vasoconstriction. So now the aorta, all the blood vessels, all the arteries in the body will constrict. So what happened? This guy is already in failure. And how did the body respond? RAS and sympathetic nervous system, causing increased heart rate, causes this to work harder, work faster. Is it pumping enough blood and oxygen?
No.
No. And now what is the body asking it to do? Work harder. What's the matter with you? Okay, pump. You're supposed to pump. So the body automatically release epinephrine. What else? Angiotensin 1 and aldosterone. This guy's job work even harder. So is the body's response helping the situation?
No.
So can this patient stay in bed at home? No, because now if your oxygen delivery is slow, what would happen to the patient's respiratory rate? Respiratory rate.
High.
And what happens to oxygen levels?
Low.
What happens to cardiac output?
Low.
So what happens to pretty much all the body's perfusion?
Low.
So what happens to urine output?
Low.
No, plus what will also drop urine output is the aldosterone, right, from the renin-angiotensin. So can you enumerate the problems now? So for the quiz next week, can you identify what are the manifestations of right side or left side heart failure?
Yeah.
Yes. Take note that the sympathetic response and the effects of renin-angiotensin aldosterone system, namely what would happen to the skin, therefore, there is sympathetic stimulation. Skin color will be
Pale.
pale, and what will be the temperature?
Cold and clammy.
Sweaty, right? Right. And what happens to my urine output?
Low.
Low. What happens to my mental status?
Confused.
Confused, right? Some restlessness, confused, I don't know what's going on. What happens to my heart rate?
Low.
Increase. Okay, but remember, it stimulates. This will cause decreased cardiac output, so automatically triggers sympathetic and renin-angiotensin. So the sympathetic nervous system will cause my heart rate to be increased. Any question on the manifestations? So we were discussing your pathophysiology and the signs and symptoms at the same time. Take note that it's automatic. Once cardiac output drops as a result of heart failure, it automatically triggers sympathetic and renin-angiotensin adaptogens. Those will be responsible for the patient's manifestations. Are we clear? Now, don't forget this, because this is not the last time you hear about this. For any cardiac condition, when we talk about dysrhythmias in module 8, will it be a different set of manifestations? It's the same, okay? So because dysrhythmias will cause decreased cardiac output, and we just discussed what is the effect if there is decreased cardiac output. Same thing. And next semester, when we talk about shock, for instance, it's still a heart problem. So the manifestations will be any different? Same exact. Are we okay so far? All right. All right, let's continue. So the manifestations, we have a chart, 25-1. Please watch the animations. They will help reinforce your understanding. Okay, congestive heart failure is an old term. Okay, you won't hear this term much because this is the old term we used to call left side heart failure. We call those patients as having congestive heart failure because of the congestion, pulmonary congestion. Because heart failure, of course, will cause congestion, right? How else will you explain that? The job of the heart is to do what? Pump blood, receive blood, pump it. So of course, if it fails, what will happen? Congestion. Okay, so right side will cause systemic congestion, left side will cause pulmonary congestion. Okay, so lung congestion as well as low cardiac output. So here are your manifestations. Chart 25-1, I already described why. Okay, so it'll be easier to remember the manifestations if you know the pathophysiology. Okay, so that you don't have to memorize things. Okay, so you understand exactly. So when you see manifestations, oh, I know what that is. Okay, I know why that is, especially. So this is for the left side heart failure. Let's discuss a few terms. What is orthopnea? No, orthopnea. When laying flat. Okay. So these patients will require multiple pillows because not all of us have a Tempur-Pedic bed, yeah? Tempur-Pedic, that's nice. You can just control it, will elevate your head of the bed. For the rest of us who don't have that bed, we use pillows, correct? Or sit in a recliner, for instance. Paroxysmal nocturnal dyspnea. Now, this is a mouthful. There's 3 conditions here. Yes, this is dyspnea, but this is paroxysmal. When you say paroxysmal, that means sudden onset, sudden cessation. Paroxysmal, okay? Suddenly comes on, also goes away on its own. Nocturnal means at night, okay? So put the whole thing together. What happens to this patient when we say they have PND? Okay, they randomly have shortness of breath at night. Okay, so they are awakened by this, right? Can you stay asleep when you have this? Can you be sound asleep when you have PND? No. This will awaken the patient, and what happens to their sleep quality now? So how does this contribute to fatigue? Okay, will make fatigue even worse. They already have fatigue because of decreased cardiac output. This will not help. Okay. And here's the explanation. So at night, because when do you have higher metabolic demands? At night or during the day? During the day, because you're up and about, right? You're working, you're in school, you're awake. Okay, so your metabolic activity is of course higher. And the higher the metabolic needs, then the more the oxygen demands will be, right? So here, when you finally sleep at night, even though your heart is weak, is in failure, fluid suddenly moves, right? Because now the heart is having less demand on it. So it will start working better. So all that edema, because remember, were they making urine when there was low cardiac output, when there was aldosterone being released? Are they making urine? No, right? The body was reabsorbing water and sodium. So the patient had less urine output. What did we call that condition again? When there is less urine output, oliguria. Okay, so patient is oliguric during the day. Now what happens at night? Because now the patient's heart is now able to meet the demands. Now there's enough blood flow getting to the kidneys, right? So now what will the kidneys do? Now make urine. So now the patient will have nocturia. And that means what will they do? If you have nocturia, get up again, wake up, go to the bathroom 2 up to 3 times a night. What happens to their sleep quality again? Okay, so you have paroxysmal nocturnal dyspnea waking them up. You have nocturia also waking them up, right? So why do these patients have weight gain? Where did this weight come from? Did they eat too much buffet? Did they do buffet breakfast, lunch, and dinner? So where did this weight gain come from? Because of the oliguria, right? Because why did they have oliguria? Remember last week, what was supposed to be the normal urine output per day? How much? 1,500 ml. Now they have oliguria, which is less than 400 ml. So what happened to the 1,100 ml that was supposed to come out as urine? That's why they gain weight. That's why now at night they have nocturia. Okay, so the body, the kidneys specifically, are trying to make up for it. Right? So is it fun having heart failure? And is this like one time or is this going to be forever? All right. Unless, of course, the patient complies with their treatment, medications, and the diet, of course, they'll live relatively normal lives. But if not, this is what you're going to have to deal with every single day, the rest of your life. So we talked about nocturia. And we just described right side heart failure. So here are your manifestations and the rationales for each one. So we talked about the liver being enlarged, fluid accumulating in your belly. As I said, congestive heart failure is an older term, right? For left side heart failure. Now, when we say acute decompensated heart failure, the number one manifestation of the patient that has this condition is pulmonary edema. Because when we say acute decompensated heart failure, is the patient's body compensating? Are the patient's heart, the kidneys, and the lungs, are they compensating? When we say acute decompensated heart failure, no. What are the frequent causes again that the patient goes into acute decompensated heart failure? They stop taking their medications. They stop complying with the diet. Okay, can you blame them? Right, like it's my birthday. Okay, do I stick with the low salt diet? No, of course we're gonna go to Red Robin, right? We're gonna go to Red Lobster. Okay, what other red stuff are there? We're gonna celebrate, yeah. And then they're gonna unfortunately pay for it the next day. So this is an acute event. So this is life-threatening. So when we have a diagnosis of acute decompensated heart failure, that means the patient is in pulmonary edema. Their lungs are wet. Both lungs are wet. They can't breathe. They can't catch their breath, can't lay down. Of course, they will go to the ER, right? Treatment here, of course, will be a lot of diuretics. This time, PO diuretics will not work anymore. Patients will receive IV diuretics. Let's go to the diagnostics. So what did we say last week? We learned about antidiuretic hormone. We learned about renin-angiotensin-aldosterone system. We learned about BNP, right? The natriuretic peptides. Okay, so how did we know again? What was a prime diagnostic finding in patients with heart failure? How do we know that they're in heart failure? BNP. Okay. Now, it explained last week that we have it in table 25-1. It talked about two types of BNP. We had BNP and then there was pro-BNP, correct? And then it mentioned something about pro-BNP has a longer half-life. Okay, so therefore it's a more reliable indicator of heart failure. Have you learned about ejection fraction in previous semesters? What is ejection fraction again? Which part of the heart? Okay, the ventricles of the heart. Now, what tests will measure ejection fraction? How do we know this ejection fraction? What test is ordered? Remember, it's the percentage of blood coming ejected by the left ventricle and the right ventricle. How did we measure that? So normal is 55 to 65%. How did we know that 55 to 65% of the blood volume was ejected? Did we do ESP? Did we call us California Psychic? Did we do palm readings? What is this? How did we measure this? An echocardiogram. What is an echocardiogram? It's an ultrasound. There are two types of echo. An echo can be transthoracic, meaning over your skin, over your chest, or it can also be transesophageal. When we say transesophageal, that's measured in the endoscopy unit, meaning we will put the probe, instead of running the probe, rubbing it over your chest, you put the probe into your throat, into your esophagus, and look at the heart from the esophagus. So which one will provide a better picture? The one over your chest or the one inside your esophagus? The TEE. So we call it a TEE, transesophageal echocardiogram. We only do that though for usually infections of the heart. Okay, so a TTE, a transthoracic, is enough to measure ejection fraction. But if we want to see the picture of what your heart actually looks like, it has to be a transesophageal, a TEE. Okay, we have table 25-1. NYHA, New York Heart Association classification. There are other classification methods, but the universal basis is the NYHA classification. So we have class 1, 2, 3, and 4. To help you remember classification of heart failure, just look at 2 and 3 because 1 and 4 is easy. Look at 1, class 1. The patient has heart failure. Okay, we have a diagnosis of heart failure. BNP is high. Hey, they have the symptoms. Okay, but they have no limitation of physical activity, and ordinary physical activity does not cause any symptoms. That's easy, right? Meaning, I'm fine. So can I go to work? Can I be a nurse? Yes, absolutely. Class 1, no problem. It's like you and me. Let's say all of us here have class 1. We have no symptoms at all. We can do this. However, this says ordinary activity does not cause any symptoms. So if all of us are asked to, they shut down the elevators, we have to take the stairs now from the lobby up to here. And we do that with class 1. Because here it says ordinary activity does not cause any symptoms. Is climbing 4 flights of stairs an ordinary activity? Do you do that every day? That's not ordinary. Okay, so therefore, will we have symptoms? So that's a different story. Okay, but are we comfortable at rest?
Yes.
Can we take a shower with no symptoms? Yes, because they're all ordinary activities. Let's go to class 4. What do these patients look like? Unable to carry out any physical activity without symptoms. So if I get up from bed to sit and dangle, will I have symptoms? Yes, that is any physical activity. I will have symptoms. Reaching out for my phone from the nightstand, will that cause symptoms? Yes. So where will you see these patients? Either in a hospital or in a nursing home or in hospice, correct? Right, so these are pre-departure people. The heart is no good. See, if any physical activity, any, okay, meaning raising my hand, it will increase my symptoms, meaning I have symptoms at rest. Here, symptoms of cardiac insufficiency at rest. I have shortness of breath just laying down in bed. All right, so that's class 4. So is it hard or easy to remember 1 and 4? Easy, okay. That wasn't a yes or no question. I said, was it hard or easy? Okay, so that leaves us with 2 and 3, right? Okay, so the difference here is, again, it's easy. 1 is no problem. Class 4, near death, right? Okay, let's do class 2 and 3. Class 2, slight limitation of physical activity. Comfortable at rest, but ordinary physical activity causes symptoms. Okay, ordinary physical activity causes symptoms. But if I'm resting, no problem. Sitting right here, I'm okay. But when I walk now to the door, I'll get short of breath. Okay, so that's class 2. Class 3, marked limitation of physical activity. Comfortable at rest, but less than ordinary physical activity causes symptoms now. With class 2, ordinary physical activity causes symptoms, but with class 3, less than ordinary will cause symptoms now. Okay, so how could this be asked in a test question on mine or the NCLEX? Okay, so you always remember the class. What does the patient look like in each classification? And in classification, what can you say is this basically trying to tell you? The severity, correct? How bad is the patient's heart failure? The example I always give is one actual NCLEX question that a graduate reported back. They said the question was, it was a pregnant person, 37 weeks gestation, came into the clinic, and the question was, and the patient was noted to be class 2 heart failure. And the question went, what will the nurse prepare during this appointment? Okay, so the patient, 37 weeks of gestation with class 2 heart failure, went to the obstetrician for an appointment. So what will the nurse prepare for this appointment? A, schedule a C-section. Schedule a C-section in the near future. And then B, follow up regarding the Lamaze classes. C, call the doctor stat, and D, prepare for C-section stat. is your answer? A, B, C, or D? So I have B. Which one? There were two. A or C? A was schedule. C was stat. Okay, the answer is A. Rationale is patient has class 2 heart failure. So this is what the patient looks like. Comfortable at rest, but ordinary physical activity causes symptoms. The patient is 37 weeks. Who are mommies here? Okay, so your moms. What is 37 weeks? What does 37 weeks look like? Is the baby viable? Yes, this baby will be alive when they give birth. So, do we have to wait until this patient reaches 38 and goes into labor? No. Is this patient qualified to do labor? Can they go into labor? They're qualified to go into labor. Look at that, class 2, comfortable at rest. Ordinary physical activity causes symptoms. Is labor ordinary physical activity? I don't know about you, but I don't want to go through labor, right? I don't have heart failure yet, but I know I don't want to go into labor. So do you want this patient to go into labor and give birth vaginally? This patient can't tolerate a vaginal delivery. So the only way this patient will give birth is C-section. You understand? So that's how it could be asked. Okay, that's just an example out there. But do you need to know the class 4 classes? Okay, you need to know what these 4 classes look like, right? So for you to answer that question. Okay, let's go straight. You can skip table 25-2. It's basically the same. This is just a different way of staging the patient, stage A, B, C, and D, but it's basically the same. If you read it, it's the same as class 1, 2, 3, and 4. It is just a different organization. Let's go to treatment now. So how do we manage patients with heart failure? First is, these are our goals. Improve cardiac function, reduce symptoms, stabilize the condition, delay progression, and then promote a healthy lifestyle. First, let's go with drug therapy. So I described to you the effects of heart failure using the anatomy of the heart and physiologic responses, right? So we said that once the patient has symptoms, which is basically low cardiac output, what is automatically triggered? Sympathetic nervous system, as well as renin-angiotensin-aldosterone system. So therefore, as described, do these two responses help the condition? Did they help the patient in heart failure? Or did they worsen the condition? Okay, so therefore, do we want these physiologic responses at all when patients have heart failure? No. So we will have to give them medications to suppress those responses. Right, so here are our treatments. Of course, they need a diuretic. This will decrease preload. We have an angiotensin blocker. There's 2 types. We have ARBs and ACEIs, correct? And then we have beta blockers. We have a table, but let's look at this section first. Let's go to the table now. So diuretics, this is a drug chart. So remember your NCLEX will have 20%, technically 17 to 19% of your NCLEX questions will be on pharmacology. So same thing on your exams this semester. So about 20% of your, or at least 20%, could be more, of your test questions will be on drugs. Because think about it, in heart failure patients, is there really non-pharmacologic things? Is there much you can do, especially if the patient is in acute decompensated heart failure? Are there non-pharmacologic things you can do? Like, can you do therapeutic communication? Patients short of breath, you ask them, you want to talk about it? Right? Or how do you feel about being short of breath? Can that solve the? No, unfortunately, we need medications. Without medications, these patients are dead, right? So that's how it is with cardiac conditions. It's all about medications. Okay. So questions, of course, will be on medications. I won't read them for you. These are the testable part is always patient teaching and nursing responsibility. That's what you're paid for. So we pay you for your knowledge of the medications, knowing what to do, okay, what to assess before, during, and after medication administration. And here are your diuretics. Here are your ACEIs, ARBs. Now, of course, on the exam, I won't say what the drug is. Okay, so I won't say the patient is receiving an angiotensin converting enzyme inhibitor. I will say patient is receiving enalapril. Patient's receiving losartan. Patient's receiving hydrochlorothiazide. Understand? All right. Because what will appear on the MAR? Will it say ACE inhibitor and a beta blocker? No. The generic names will appear, correct? So this is the same thing. So you'll see a MAR, patient is scheduled to receive metolazone, right? And then which of the following will the patient assess first before giving the medication? Or it could be, what will the patient teach the patient? All right? Or the following statements indicate that the patient understood the teaching while being on metolazone. Make sense? Here are beta blockers. And why are these patients receiving these particular medications again? Okay, so the answer is on column number 2. What is the effect of this medication? Right? How does it work? How does it help the patient with heart failure? So these are your standard medications. So is this patient on one drug? They'll be on 4 or more. Right? So diuretics, definitely. Then they'll have beta blockers. And as far as ARBs, it could be and or. Because now we have combination drugs. This one, for instance, ARNIs. Have you heard of or have you seen it on TV? Entresto is the brand name. That is sacubitril valsartan. Combination, an ACE inhibitor and an ARB in one drug. Right? So they combine them now. And all those, of course, are your beta blockers. This is not a very popular drug, so you can skip this one. Then you got hydralazine. These are now vasodilators. So these are used for acute and as well as chronic management of heart failure. So for hospitalized patients, when they have acute hypertensive episodes, we do give hydralazine, 10 to 20 milligrams IV push. Then we have digoxin. Digoxin increases the strength of the contractility of the heart, but it's still on our textbook, but very few people nowadays are prescribed digoxin. Okay, you'll learn why later when we get to module 8 later in the semester. But for digoxin, since this is retained in the bloodstream, meaning the half-life of this is quite long, so it stays in the bloodstream, right? And the how the drug works is it enters the body, particularly it enters the cardiac cells via the sodium-potassium pump, meaning without potassium, the drug cannot enter the cell. I repeat, without potassium, digoxin cannot enter cardiac cells. So what happens if the patient's potassium levels are low and they're taking digoxin? They will have, say, so what will happen to the drug levels? Because I'm taking it, right? I'm taking it. I didn't know. Let's say I'm taking 0.1 milligrams every day, which is 100 micrograms, yeah? So let's say I'm taking 100 micrograms per day. I have no idea my potassium levels are low. So I keep taking it for a whole week. My potassium levels have been low all week. So what will happen to me? Toxicity. Okay, I will have very high, dangerously high levels of this drug in my bloodstream. Why? Potassium is low. The drug cannot enter the cardiac cells, so they accumulate in my bloodstream. Why in the first place will I have low potassium when I have heart failure? What are the other drugs I'm taking? I'm taking diuretics, which will lower my potassium. Not just potassium, but sodium levels will be low, calcium will be low, all electrolytes will be low, but especially potassium. Okay, so it's common. I'm taking diuretics, of course. I expect that I have the potential to lose potassium. And I have to be careful, therefore, if I'm taking digoxin with it. Understand? So since it can't be avoided, because can the patient choose, like, oh, I won't take my diuretic because I'm taking digoxin. Can they do that? No, these are prescribed by the physician. So since they always are at risk for this toxicity, what will be your best responsibility? Sorry? Are you there at home? Patients at home. These patients are, these are chronic conditions. They're not in the hospital for the rest of their lives. They're at home. They're at work. So what's the best thing to do? Say it louder. What's the best thing to do? Teach the patient what? Is that safe to do though? What if the potassium's high? So what would be the best teaching? Signs and symptoms of what? Of toxicity. How do I know I'm already experiencing digoxin toxicity? All right, so the answer for the toxicity is, by the way, there's a teaching here for patients on diuretics. This is chart 25-2. We take you to the top. Here's digoxin, and here is the toxicity. Signs and symptoms are what? Anorexia, nausea, visual disturbances, confusion, and bradycardia. Let's specify the visual disturbances. Now, these visual disturbances will be halos around lights and blurred vision. Meaning when you look at these, especially if it's incandescent lighting here, not white, like yellow lights like this, there will be a ring around that light. Okay, so those are blurred or halos around lights. And of course, the bradycardia. How will they know they have bradycardia? How do you know if you have bradycardia? What is bradycardia? So how do I know my heart rate is low? Okay, teach them pulse oximeter. What if I don't have one? Those things cost $6. I don't have $6. I'm retired. I'm on Medicare. I have a fixed income. Teach them how to take a pulse, of course. We'll skip the IV infusions. We'll talk about these when we get to shock, because these drugs are used during shock. Cardiogenic shock will be the first topic on your fifth semester, first week. Anticoagulants are only if the patient has a heart failure caused by AFib. We'll talk about these heart rhythms and the complications and treatment later under Module 8. Let's go to the non-pharmacologic interventions now. Nutritional therapy is a very important aspect, and it's based on sodium restriction. Okay. So there are different levels of sodium restriction. So what is sodium again? With our nutrition, with our meals, is it important? Yes. Without salt, do you want to eat that food? No way. Throw it out, okay? Or put salt in it, right? Are these patients allowed salt?
Yes, but not.
Not a lot, okay? Not a lot of salt. So the patients will be, of course, asking for food that tastes good, yeah? Otherwise, what's the purpose of eating if it doesn't taste good? Yes? Just like, let's say, sexual activity or watching a movie. No, the point of anything is you enjoy it, right? So why will you eat food if you don't enjoy it? Yeah? Just because you're hungry doesn't mean, oh, I'm gonna eat cardboard. You have to enjoy your food, yeah? So it has to taste good, and nothing tastes good if there's no salt in it. Okay. So since they have sodium restriction though, so what will we have to do? Salt substitutes. Okay. A warning about salt substitutes. We discussed this already under potassium last week. Yeah. We talked about fluid and electrolytes. You still remember? Okay. So what do salt substitutes contain? Okay. So instead of sodium, especially the cheap ones. So cheap salt substitutes, by cheap, I mean 60 cents salt substitutes, $1. Those cheap ones are made of potassium. The more expensive ones have non-potassium ingredients in it. By more expensive, of course, these are the $6, $7. That's expensive for a salt substitute. Yeah, I mean $1. Yeah, I'll buy that, but $7 for a spice. It's not even a meal, right? So that's kind of, again, always think about who are these patients again who have heart failure? Are these young people like you and me? These are retired people, fixed income people. All right. So they have to watch. They live on a budget. Okay, just like the rest of us eventually. Supplemental oxygen, they may be prescribed oxygen at home as well, definitely in the hospital, but at home, yeah. So these patients, remember the risk factors, they have obesity, correct? Obesity, hypertension, diabetes, high cholesterol. Okay, so most of these patients may have sleep disorders. Sleep apnea can exacerbate heart failure and then vice versa. Do you know how CPAPs work? Yeah, CPAP or BiPAP? Correct. So this one is it's not a ventilator. Okay, so a ventilator delivers a breath, yeah? So CPAPs don't deliver a breath. They just deliver pressure. Okay, so they blow air pressure into the patient's airway. How it works is actually it, especially BiPAP, that actually helps lower. You still remember the term preload? What do we mean by preload again? You discussed this with Dr. Farrington. What is preload and what is afterload? Forgot to ask if you guys even understand these terms.
The chamber goes after.
Okay, so let's start with preload. So Gabby, what do you understand by preload?
Uh,
Correct. So preload is basically blood volume. Okay, so when we talk about preload, we're talking about blood volume. How much blood is in the patient's body? All right. So in heart failure, what do you want to do with preload? Do you want to increase it or do you want to decrease it? You want it high or do you want it low? Anybody? What do you want to do to the preload? of a patient with heart failure, with heart problems? Do you want the preload high or low? I told Gabby preload is blood volume. So how much preload do you want the patient with heart failure to have? Low preload. What drug will help lower preload? We just looked at the drugs. Here, table 25-1. Which drugs will lower preload? Diuretics. Let's go to afterload. So afterload, what is that really referring to? Okay, so afterload is the resistance that the heart must meet in order to pump blood. So thinking about anatomy and physiology, if preload is referring to the blood volume, what is afterload referring to? That's preload. We already discussed it. Preload is the blood volume. So that means afterload must be, because afterload description, the definition is the amount of resistance that the heart must meet in order to pump blood. So what is that? What will increase resistance as the heart pumps blood? It refers to the blood vessels, arteries and veins. So what do you want? So when your arteries are dilated, what happens to afterload? And what happens to afterload when the blood vessels are constricted? Correct? Okay, very good. So therefore, if the size of the blood vessels are smaller, what happens to afterload? Again, if the size of the blood vessels are small, meaning are they constricted or dilated? They're constricted. So what happens to the resistance? Increases. So therefore, afterload is high or low? Afterload is high. The resistance is high. Again, the definition of afterload is what? The resistance that the heart must meet as it is pumping blood. Okay, so what happens to the resistance if the blood vessels are dilated? The resistance is, why say high? You just said it's high when it's constricted. Can't be high in both conditions, right? So we described it already earlier. So with the straw, right? With the syringe, what size syringe are we using when we flush a central line? So why was it 10, not a 3? Okay, so you just told me the pressure is higher with a smaller diameter syringe, right? So same exact thing here, same concept. Okay, so look at it by concept. It's the same idea, right? So what drugs here will lower afterload? Describes there, BP, you see afterload, there's preload. So what drugs decrease afterload? So therefore, what do these do to the blood vessels therefore? Do they dilate or do they constrict blood vessels? These things dilate blood vessels because they lower afterload. Okay? You understand? Any questions? Any clarifications? Any problems with preload, afterload? Because these are general terms you'll be hearing. Okay? So you're discussing these with your doctors, you'll hear these terms repeatedly. So when we say preload, what are we talking about? Blood volume. When we say afterload, what are we talking about? which is,
Going to the heart.
yeah, so what is this referring to? Afterload is referring to what?
Fully the arteries and veins.
Yes, so what are we talking about? Blood volume or blood vessels? Blood vessels. What do you want to do to the blood vessels when we say a patient with heart failure? Because dilation will cause decreased afterload. So therefore, in conclusion, what do you want to do to the preload and afterload when a patient has heart failure? You want to increase it or decrease it? Sorry? Decrease preload, decrease afterload. That's what the table says, yeah? Table 25-1. What do the drugs do? Decrease preload, decrease afterload. So here for digoxin, is this going to affect preload or afterload? Neither. Because how does this work? Okay, it affects only the contractility of the heart. Doesn't affect blood vessels, doesn't affect blood volume. All right? So where will nutrition therapy come in? So when we give decreased or restricted sodium, low sodium, what aspect are we affecting? Preload or afterload? Very good, preload. Because when you lower sodium, you're lowering blood volume. Do you understand the words that are coming out of my mouth? Okay. We'll skip all these others because these are ICU specific. We're not likely to deal with the intra-aortic balloon pumps or ventricular assist devices on a general med-surg floor. Okay, so we'll skip them. Not necessary. They're nice to know, but not important for entry level. All right, for exercise program, you have a chart there, the end of this chapter. Chart 25-3, what to do before and after exercise and what type of exercise is recommended. So, and how long. Okay, so please read them on your own. Won't read them for you. Teaching about sodium, chart 25-4. Now, not just the salt itself, because some people can be very literal, especially when they go out to eat. Will restaurants really break down the amount of sodium in their food? Not at all. They're only required to publish what? The calories, right? So you see that in restaurants, we see the number of calories with each meal, correct? Go to IHOP or any restaurant, they have them, right? Because they're required by law. However, for sodium, they're not required to break down how much sodium is in there. So most restaurants, if it's cooked outside a house, do you have any control over what goes in there? No, you can ask, right? But doesn't mean they'll do it, right? My mom always insists, no MSG, please. But what will the Chinese restaurant do? Yeah, they'll say, oh yeah, no MSG, no MSG. Oh, of course, yeah. They want to sell the food. Of course, they'll say, yeah. Right. Of course, it tastes good. Anything with MSG tastes best. Okay, that's it. Any questions on heart failure? Okay. Before we go, let's go to the teaching. Now, the teaching, I'll just summarize the teaching here in chart 25-6. The acronym is MAWDS, MAWDS. The teaching is MAWDS. That stands for medication, activity, weight, diet, and signs and symptoms to report. I repeat, MAWDS, the breakdown is medication, activity, weight, diet, and signs and symptoms to report. Okay, so let's take a look at M. So M, that was table 25-1. Read the purpose and your nursing responsibilities for each drug. Activity. So we already have an exercise program chart. Yeah. So for how long, what type of exercise, what do they do before and after exercise? And W would be weight. So what is the teaching about weight? You learned this from fundamentals with what? With same
The same.
clothes, same time, same. Can't be same day. What about tomorrow? Okay. So same scale, yeah?
Oh,
Same scale. Okay, very important. Same scale. So that's weight. So D, diet. We have the sodium. There's a chart also for the sodium. And then S, signs and symptoms to report. So what do you think will be reportable signs and symptoms? Are we referring to chronic or acute signs and symptoms?
Cute.
Okay, so can you distinguish between acute and chronic symptoms?
Yeah.
So when we say expected signs and symptoms, what were those expected signs and symptoms again? Of right side heart failure? Okay, so all right, so those congestions. Okay, what about left side heart failure? Okay, so which one is more acute, the right side or the left side?
The lungs.
Which is the, which is which side? The left side, okay? So overall, you can say right side heart failure manifestations, are any of them acute? No, most of them are chronic, right? Edema, yeah, they're chronic. What about the left side? Most of them are acute. So which ones are you going to teach the patient are reportable? Left side or right side?
Left side.
Left side. Okay, take a short break. Come back at 1:32.